Welcome to this special edition of Diabetes Core Update, where we will discuss an update on continuous glucose monitoring. The context here is that many of us are using CGM in our practices and recognize its immense value. Others are still getting used to using it or haven't really used it a lot yet at all. We want to include something in this podcast for everyone. I'm your host, Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special edition of Diabetes Core Update is sponsored by Dexcom, the #1 HCP recommended CGM brand and creators of Dexcom G7. Dexcom G7 is a continuous glucose monitoring system designed for patients with all types of diabetes. The American Diabetes Association recommends the use of CGM in people with diabetes, as CGM is clinically proven to lower A1C, reduce hyper and hypoglycemia, and increase time in range. Getting started with Dexcom G7 is easy, with only one prescription needed. Visit dexcom.com/ADA for prescribing information and to sample Dexcom G7 for free. Joining us to discuss this topic is Dr. Eden Miller, who is founder of Diabetes Nation, a nonprofit organization, and CEO of Diabetes and Obesity Care in Bend, Oregon, and who lectures nationally on a number of different aspects of diabetes, including CGM. Welcome, Eden.
Thanks so much, Neil. Such a pleasure to join you today, discussing how technology is really changing the face of diabetes management.
It really is. And also joining us is Dr. Eugene Wright, who is the Medical Director of Performance Improvement at the South Piedmont Area Health Education Center in Charlotte, North Carolina. He is also a consulting associate in the Department of Medicine at Duke University Medical Center in Durham. He served as the inaugural chair of the ADA Primary Care Interest Group and as a member of the ADA American Heart Association No Diabetes by Heart Scientific Advisory Group. Dr. Wright is an associate editor of Clinical Diabetes. Gene, welcome.
Thanks, Neil. I'm honored to be with you today and one of my favorite sugar queens.
Oh, thank you.
Eden, I know you've had the opportunity to actually speak to the Oregon State Legislature on the importance of CGM to diabetes care. And let's start with that. What is the case for broad use of CGM, and for whom should we think about recommending CGM?
Yeah, I had the unique opportunity to testify on a number of occasions with our Oregon State Legislator, opening the coverage and the utility for our lives here in Oregon. And it really is a plethora of data in regard to improvement in A1C and time in range and cost savings. Not only that, but quality of life. And so one of the things that I did is I tried to compile a lot of the scientific data to show them all those different concepts, because CGM is not just a new way of just finger sticking. It's a whole new eye-opening, microscopic, individualized look at those people of all stages of diabetes, from early diabetes to pre-diabetes to advanced diabetes. And so it really is for all persons who want to know more about lifestyle and all of the different things that go into their personal care. And so it's hard to say who's going to benefit. I think Gene would agree with me that all persons would benefit from the information that's provided of continuous glucose monitoring.
And Eden, when you say all persons would benefit, why do you say that?
Because diabetes is one of those diseases, very unique for us, that every moment does matter. We don't follow cholesterol like that. Yeah, we follow blood pressure a little bit more, but with diabetes, it's metabolism, and it matters. And for so long, we were blinded to the glycemia. For whatever reason, utility, advancements, we just didn't understand. And now when we take a person out of the past A1C metric into the present glucose and predict the future, we now enable the person to guide and direct their own journey, to see that individual effects day by day, to go beyond even generalizing. I'll tell you, Neil, we are seeing how foods and stress and medications affect people on the individual level, beyond just the group or the herd, the individual level, and talk about customizing care and empowering the person to take hold of their own care as well. It's the invention for this century for diabetes management.
It's fascinating, Eden, when you say that. We've talked a lot in general in medicine about personalized care, individualization of care, and often that's focused on genomics. But here, what's fascinating to me is that we're actually seeing the end result of whatever the genomics are here. The way you respond to a mix of carbs, proteins, and fats may be different than the way I respond to that same mix in that same exact food. And so we really do achieve that individualization of care that we've been hoping for. Any thoughts you have, Gene, on that topic?
I think Eden is very articulate when she talks about this. And you're absolutely right. The kinds of information that we see now, you talk about different people that may respond differently to the same glucose load or carbohydrate load. That can even vary from day to day within the same person. And we now can see that. And people are now feeling less that the disease is controlling them and that they have a greater opportunity to control their lives, of which diabetes is just a small part.
Yeah, it's fascinating because we're all curious about ourselves, and it pulls on that innate curiosity that we have to see how we're doing. Now, is there any evidence out there to say that actually when you use a CGM, that feedback loop that we're talking about actually makes a difference?
I'll take a shot at that first. Yes. And in fact, we penned a paper not long ago, is CGM a tool or an intervention? And what we determined after looking at a lot of data about how CGM and how blood glucose has been used, it is a tool that facilitates an intervention, not just on the part of the healthcare practitioner, but probably more importantly on the part of the patient. And what I mean by that is that with the information that's provided, with the CGM and the reports, patients are able to, as Eden says, see the different aspects of what's going on with glycemia. They see the impact of when they take their medication, if they take their medication. They see the impact of what they eat, when they eat, and all of these things that we think influences their behavior.
One study Gene and I did, so I remember that. It was pretty pivotal, at least for both of us, is that we looked at CGM in a unique demographic group. I think we all would agree that CGM, continuous glucose monitoring, is standard of care for type 1 diabetes. It is. It's recommended, it's advised. But when we looked early on at those individuals who had type 2 diabetes, and they were on either oral anti-diabetic agents plus one shot of basal insulin, or just oral anti-diabetic agents, that was really a population that as a whole, we didn't really consider would benefit. I would say the average individual or the average provider thought there wasn't a lot of utility with that. But what we found, and I think both of us were equally surprised, is when we looked at the mixed cohort, that whole group of individuals, we saw an A1C percent drop, the 0.8% of the entire cohort. But if we took out those individuals who were just on OADs and injectable GLP-1s. So in other words, no insulin, nothing that we traditionally talk about coverage, because CGM is just for preventing hypoglycemia, right? Nothing else. But if we looked at those individuals on OADs and GLP-1s, they had a reduction in minus 1.5%. Where is that coming from? That is coming from, this is a group of neglected people who we didn't talk about monitoring glucose. And we never were able to bring in the person and their own disease by equipping them to make those decisions. And I think in part, this might have been some of the data that helped CMS try to cover this, which they did in 2023 for type 2 persons on one shot or more. And it's that beginning, but it does really show you that if you have diabetes on any level, whether it's early or middle or later, insulin or lifestyle, you can have a tool that is your own personal GPS that will tell you where you're going. It will tell you how you got there, and it will give you information as a person and as a healthcare provider. And it's in the middle. That report, that data allows the person and the prescriber to come together on a common set of data. And there's not a lot of things like that in medicine.
Eden, you're absolutely right. And anecdotally, many of us had seen people who were not on insulin that had done better, but we didn't have data to support that. When we looked at this retrospective real-world study and we looked at what people did, that really lined up with what we felt, but we had just never seen anything that really supported it to the level. And you're right, the A1C level change with people who were not on insulin therapy was nearly twice what people who in the entire cohort was. So it was remarkable.
It's remarkable. It's incredibly important evidence because I think we intuitively know that people who are vested in their care do better. CGM helps people stay vested, stay interested. But boy, oh boy, to have that sort of evidence about an A1C drop that is as good as or exceeds what you get when you add an additional medicine is strong argument for broad use. Now, Jean, can you address a little bit or share with us some information about insurance coverage for CGM? Because when we think about broad use, obviously that's relevant. CGM coverage has improved over the last few years, but can you give us a sense where it's at now?
Insurance coverage for CGM has been improving over the last several years, and in part because more and more data is coming out and evidence about the impact of CGM, as we've just talked about. One of the particular high points of insurance coverage was in April of 2023, when CMS enhanced or improved their guidelines to include CGM in a broader group of patients who had Medicare. And I just want to read their statement because it was pretty impactful when it came out. Eden and I called each other up right away and say, boy, this is really big news. But Medicare has said that they will cover continuous glucose monitoring to include a receiver and any of the related supplies, a sensor, transmitter, if your doctor says that you meet all of the requirements for Medicare coverage, and they listed those. 1, you must have diabetes. Yeah. 2, you take insulin or have a history of problems with low blood sugar. That's the key words in that one. If you have problems with low blood sugar, if you have a prescription for testing supplies and instruction of how often to test your blood, all of that, and have been trained or had your caregiver trained how to use the continuous glucose monitor. The only other requirement that they recommended was that you make routine, either in-person or Medicare-approved telehealth visits with your doctors within about 6 months of being the prescription. Now, the American Diabetes Association wanted to clarify that because sometimes government language can be difficult to interpret if we're not accustomed to that. The ADA provided their guidance and interpretation, if you will, of what the CMS or Medicare changes allowed. It says that Medicare beneficiaries with diabetes may be eligible if they have diabetes. That's pretty clear. Their healthcare provider concludes, or your caregiver, that you have sufficient training in CGM prescribed as evidenced by providing a prescription. And what that says is you have a prescription for CGM. The CGM is prescribed in accordance with FDA indications for use. All of them are indicated at this point. And the beneficiary for whom the CGM is being prescribed to improve glycemic management meets at least one of the following criteria: either insulin treated or has a history of problematic hypoglycemia with documentation of at least one of the following: recurrent, more than one, episodes of level 2 hypoglycemia, or one episode of documented level 3 hypoglycemia, which is an important factor because level 3 hypoglycemia says that you have had to require the assistance of another person, and it is not dependent on what your blood glucose was. So that's an important one. Level 2, you have a documented level 3. You required the assistance of another person characterized typically by altered mental status or physical state requiring that assistance. And then the fifth one was that you had to have a telehealth or an in-person visit with your practitioner within 6 months of the prescription to say that you still needed it. That, I think, now has really allowed people who were on oral anti-diabetic agents, particularly that are related with hypoglycemia, to now have access to this tool. There are a couple of resources that, Neil, I'm sure you will put in the show notes where you can actually go and see these criteria, and some of them will actually walk you through what the insurance coverage is in your area for a given insurance provider and the patients that you want to prescribe for this and guide you through writing a prescription.
Gene, that's so helpful, and that's an important update because that has broadened the insurance coverage over the last few years, and it's helpful for us to learn about that. Let's shift now to some practical aspects of integrating CGM into primary care practices. Can you go over, for those of us out there who are not used to doing CGM a lot, how do you read CGM? What's the main data that you review with patients, and any pearls you have about how to look at it?
Sure, Neil. The ambulatory glucose profile, or it's commonly referred to as the AGP, is the informative representation of a large amount of glucose data, up to about 1,440 data points per day, that are collected over several days and organized, analyzed, and summarized into this actionable report that we call the AGP. There are several ways to approach interpretation of the AGP, and many of them have been described in great detail throughout the literature. The approach that I use to both understand and interpret this information is to, first, I want to assess the adequacy of the data that's been captured in the report, with a target of at least 70% of the available data that is needed to get an accurate assessment. If you have a 10-day sensor, at least 7 days worth of data. If you have a 14-day sensor, 70% of that. The second thing I do is I review the glucose statistics, which are in the upper left-hand portion of the AGP report. This includes things like the time in range, time below range, the time above range, and each of these has some guidance right next to it on the report about what the target ranges are for the patient that you are looking at. And these are expressed in percentages of the 24-hour day and in minutes per day. So you can get an idea of how much time the patients are spending in each of these states. The third thing I like to look at is the mean average glucose and the glucose management indicator, or the GMI. This is in the lower portion of the statistics section, and it's an indicator of the mean average glucose over the time that the sensor is worn, and that represents the data that's captured. This roughly correlates to what we would say is an estimated A1C if you were to live for 3 months like you did during the 10 to 14 days that you were wearing the sensor. The fourth thing that I like to look at is the modal day graphic. And this represents all of the glucose that occurs, all the glucose values that have occurred over the sensor wear period, as if they occurred during a single 24-hour period. Now, what this allows me to see very quickly if there are any variations in the glucose values, either inter and intraday, and if the glucose curves are flat or variable. I like to talk with the patients when I show them this and say, this is the only place in medicine that a flat line is good. Finally, I like to review the daily graphs portion at the bottom with the patients. And I ask the patients to tell me what they see and observe about any highs or lows on any particular day or parts of days, and what they recognize might be related to or what was going on at that time. Also, we discuss what day or days were their best days during that time and how we might make a plan to make those days the norm for them. Now, depending on the patient and the amount of issues that they identify, the entire process takes about 5 minutes or less at first, and it gets progressively less time as you become more proficient in recognizing these patterns.
Eden, I'm interested from your point of view, how you sit down with patients and how you go over it with patients, because I often find that looking through the report together is one of the most valuable things that happens.
Absolutely. You also have to set yourself up for success when you identify persons with CGM and you say, hey, I'm going to consider you for this. You're going to see in real time what your numbers are. And I really make sure that nobody is going to emotionalize that information. This is not an opportunity for seeing all the blood sugars and think about all the different times during the day when you're doing either above ideal. So I tell the individual, look, I'm going to get data, and that data is going to tell me all the places you go, how you got there. I want you to be mindful of that. I don't want you to write me a novel, but I want you to journal this information, because when I come and see you again, and you bring it back in a few weeks, I want you to tell me one thing. What did you learn about yourself? What have you revealed? And so I plan for that success. I say, I want you to be mindful, maybe of stress or food or different things. I sometimes use terminology of the Fab Five. I want to know the fabulous 5 foods that don't affect your glycemia, that you like, that you go, hey, this really does pretty good. I also want to know the forbidden 5, those 5 foods that you thought, oh my goodness, I had no idea oatmeal hates me, that it was so bad for my glucose. I really try to individualize it. And here's why, because I set up a time between 2 and 4 weeks. I want to make sure that I get them back in to look at the data in a timely fashion where it's fresh, right? And I say, be prepared. I put it on my chart on the appointment, CGM review. So I know, so my staff knows. And when I sit there, I walk in and I say, what'd you think? And then I give them that open-ended opportunity to share with me all the different feelings. And then I say, what did you learn about yourself? I sit down, we talk about we go through the data like we did, which Jean did such a great job. I turn the screen around and I say, what do you see? And tell me something about yourself that I didn't know and you didn't know. And then I allow them to share first, because guess what? It's their glucose levels. It's their journey. And then I come back around and say, okay, let's make a plan. Given this new information, that plan could be lifestyle, that plan could be stress reduction, that plan could be, you know what? You're taking your medicine more and you're noticing the effects of it. Or it could also be augmenting your intervention, both escalating or de-escalating based on what pattern of data in front of you.
Eden, that's amazing to hear how you do that. And I'm just thinking of things that I am now going to do that I haven't, one of which is asking a patient to keep a journal. What a great idea. Jean, any other thoughts you have?
Eden has articulated so well. The thing that I like to let the patient know that diabetes is a journey for them, right? And I can provide them driving lessons. I can get them resources to help them learn how to drive this journey. The CGM is their roadmap, or as Eden puts it, their GPS that helps them navigate their journey. They are now in control of where they're going, how fast they want to get there. And Eden, one of the things I borrowed from Eden, when patients understand the A1C and they say, okay, the A1C is what I want to do. That's where I want to get to. That's your target. That's your destination. The CGM helps let you know how you get there. And that really resonates with them in terms of this driving and this journey that they have. And many of them feel like they've been on a journey with diabetes all along, but it's been the other way around. The journey, the diabetes has been driving them. Now they get to get into the driver's seat.
That is fantastic. Let's move on now to challenges. Eden, can you share at least one challenge that people encounter with CGM use?
Yeah, I want to do the challenge that we see that resonates both with the wearers and the prescribers. And that is that continuous glucose monitoring, it's not a blood glucose monitor. It's a plasma, you know, that little watery stuff in your blood, interstitial monitor or glycemic monitor. It doesn't monitor blood. And so as a result of that, we get a lot of this concept of I stick my finger and it's a different number and it must be inaccurate. Remember, the accuracies of these systems are so good. They run automatic pumps. You can bolus without finger sticking. And I think that when it comes to how to navigate that a CGM is an interstitial glucose monitor, it's often a trend monitor, which means it might lag behind a few minutes. And so there are some things that can affect it. Number one, If you lay on it, you can have this localized effect of decreased flow to the sensor. So we call it a compression low. If you're doing hot tubs, it might spike because you get an increase in the amount of fluid or interstitium that it reports. If you're super cold. So you can see that there are small things that don't decrease the credibility. They just show the localized environment. And so I make sure and I talk to them about that. That's just what it is. And understanding, I think another is that early application in that first 24 hours. Remember, there's some trauma involved. And so sometimes blood gets around that sensor. And so the glucose hides for a little while. So if you explain that to prescribers, if you explain that to patients, they go, oh, well, I get it. And so it brings them back that confidence and it removes some of those barriers of trust.
Fantastic. Jean, any other challenges that you can think of?
I'd just like to pick up on one that Eden mentioned, and that's the one about sensor lag. That's real, and I think you have to emphasize that when the blood glucose is changing very rapidly, so if you see someone, their blood sugar is rising or falling by the trend arrows very rapidly, you really need to have them do a finger stick to confirm what the blood glucose is, because there is this lag, and that lag may be longer when there's a very rapid change in blood glucose. So for low, be sure that you're confirming that. The other challenge is more global in the sense that many people who've not been in control of their diabetes for a while find it scary to all of a sudden now have all of this data or information that says that, wow, I can control this. And they're a little reluctant to do that because it's different. One of the things that I've found that's been most rewarding is that once they see the CGM data, they understand, as Eden said, the Fab Five and the Forbidden Five. One patient told me she actually felt liberated. And it's one of those challenges that is very fulfilling for them to overcome.
Yeah, knowledge is power, and this gives you a lot of power over the choices you make, and then you see the results of those choices. Jean, any quick thoughts for clinicians who haven't been prescribing CGM yet and might be a little bit afraid of how they do this? Will they be competent enough? How should they get started?
I'll tell them to do what I did. Wear a sensor. Wear it for yourself. One, you'll see how easy it is to apply. You wear it, you see the information that is now coming out. And without a doubt, the physicians that I've had, clinicians that I've had that have worn that, they said, my goodness, I had never known all of this stuff that I'm seeing. And these have been people, I've actually had physicians who had prescribed it and then wore it themselves, and they became even more excited about it. But just being able to see, as Eden has articulated, how food, how behavior, how lifestyle changes glycemia, and it gives you a new sense of control.
Yeah, I did that, and I found that it was an epiphany. This is not hard to do. I was afraid of it. It was easy to do, and I was simply fascinated about the results of what was going on with my choices all day long. The other thing that I'll recommend to our listeners who might not have prescribed it often is don't be afraid to learn with your patient. When your patient comes back, to go over on their smartphone the results of their CGM. When I first was learning, the patients would explain to me what all these different things mean. Yes, I listened to a podcast. I looked actually at a webinar that both of you did on this topic. But some of the people who taught me the most were my patients as we would go over things together. Eden, are there any new exciting things coming out about CGM that I think would be helpful for our listeners to know?
Yes, there are some really pivotal stuff coming out. First off, continuous glucose monitoring is going to be over the counter this fall. There'll be a couple different iterations. I want to make sure our listeners understand they're not going to be the same one as we're currently out in being prescribed, as those have different levels of testing and alarms and indications. But it's going to really open up the access. And if you haven't jumped on board the train of CGM, you're going to need to soon as a clinician, because it's going to come to your doorstep. But for me, one of the biggest things is that my husband, Dr. Kevin Miller, and I, as well as Richard Bergenstahl, the founder of Time and Range, we are actually currently embarking this fall on a study to look at what is a normal glucose. I know that may sound quite passé, but it's true. We really know what time and range is and targets for those with diabetes, but we don't know what a normal blood sugar is. In addition, we're going to look at the early diabetes, that pre-diabetic state. But as you've heard me before, I don't like to use the word pre-diabetes. It's like being pre-pregnant. You just can't have it. And it's early diabetes. And so in identifying people who are at risk for developing diabetes, which is 98 million people, we're going to be illuminating to them what their journey is. And then finally, a ketone dual glucose sensor that Jean and I are our spider senses are going off. We're going to learn more about ketosis than we ever have. It will be an amazing impact on complications, hospitalizations, morbidity, mortality, and it's going to open up an area of metabolism that we have been absolutely blind to. And so those are those top level things that are coming.
Absolutely fascinating. Eden, we're almost out of time. Are there any final thoughts you want to share with our listeners?
As I mentioned, CGM is the GPS of diabetes, taking the individual out of the past into the present and predicting and being in control of their future.
Jean, any final thoughts you have?
Eden has said it so well, but what I will say is, for me, CGMs have the ability to fundamentally change the way that we and our patients manage diabetes. With the improved accuracy and the availability of large amount of glucose data that has been organized, analyzed, and summarized in this AGP report that helps both patients and their practitioners identify better targets for treatment and facilitates interventions that leads to better diabetes care.
Jean, Eden, thank you for sharing your expertise with us. And of course, to our listeners, thank you for joining us to talk about CGM. This special edition of Diabetes Core Update is sponsored by Dexcom, the #1 HCP recommended CGM brand and creators of Dexcom G7. Dexcom G7 is a continuous glucose monitoring system designed for patients with all types of diabetes. The American Diabetes Association recommends the use of CGM in people with diabetes, as CGM is clinically proven to lower A1C, reduce hyper and hypoglycemia, and increase time in range. Getting started with Dexcom G7 is easy, with only one prescription needed. Visit dexcom.com/ADA for prescribing information and to sample Dexcom G7 for free. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.